Today we will discuss about short cervix. Short cervix in pregnancy, it basically predicts the chances of a preterm labor. What is cervix? What does it mean to have a short cervix? What are the symptoms of short cervix? How to diagnose a short cervix? What to do in case of a short cervix? What is cervical incompetence? What is preterm labor? When to do a cervical encerclage? When not to do cervical encerclage? When to simply put patient on progesterone in case of short cervix? And can short cervix be prevented? Can cervical length be lengthened? We'll discuss all these in today's video. Good morning, good afternoon, good evening, wherever you are. I am Dr. Rajat and you have started watching our YouTube channel, The Fertility Gynecologist. What is cervix? This, ladies and gentlemen, this is the uterus and this is the cervix. For a common person who is a non-medico, uterus and cervix is the same organ we call bachedani in Hindi. But this anatomically and for all medical people, uterus is a separate organ and a cervix is a separate organ. It is a part of a reproductive system which is found at the lower end of the uterus. And a short cervix before 24 weeks increases the chances of normal preterm delivery. It can be diagnosed on a pregnancy ultrasound. So mechanical failure of cervix is very common and mechanical integrity of cervix is very important for maintenance of pregnancy. A non-pregnant cervix is about 5 cm long and roughly the cervix in pregnancy has to be minimum 3 to 4 cm long. Cervix is from the internal os to the external os. It is composed of a musculofibrous component which is 85%, which comprises of extracellular matrix and aminoglycogens. And approximately 15% of cervix is comprised of smooth muscles which are circumferential, which do not, again I am emphasizing the circular muscles which are circumferential, they do not contribute to the cervical strength. The ultrastructure of collagen fiber is the major component of a mechanical function of cervix, which consists mainly of type 3, type 1 and hydroxyproline, which is the major component of the collagen of cervix. And that is why a improper functioning and a remodeling of the extracellular part of collagen component plays a very important role in the cervical incompetence. In first trimester of pregnancy, the cervical length is roughly between 4.5 to 5 cm. In most of the cases, it is up to 3.5 cm or 35 mm at about 28 weeks. And after that is the time when the cervical length starts decreasing. So what is the significance of a cervical length? In all the patients who are first time pregnant primary patients who have no history of a prior preterm birth, the cervical length of 20 mm or 2 cm is fine. But in all those patients in whom the cervical length is 25 mm but there is a prior history of a spontaneous preterm birth, in those cases there is an increased risk of preterm delivery. A meta-analysis was done in 2011 which found that use of vaginal progesterone helps in prolonging the pregnancy. It increases the chances of prolonging the pregnancy past the age of viability, past 34 weeks, and decreases the chances of a spontaneous preterm birth. So would patient come and tell me that, sir, madam, I am having a short cervix? No. In most of the cases, there are no symptoms of short cervix. Patient is usually asymptomatic. It is mostly an incidental finding on a transvaginal ultrasound. But in few cases with cervical insufficiency, there might be a feeling of discomfort, vague, dull, aching, low abdominal pain. Sometimes there may be a discharge, sometimes there may be a spotting, sometimes there may be a back pain. So that is why I, as a gynecologist, if any patient complains to me of a lower abdominal pain, of a back pain, of whitish discharge, of spotting PV, I always do transvaginal ultrasound. I have told my patients, any patients, normally we examine the patients in first trimester, first 3 months by a transvaginal ultrasound. Once it is about from 4 month onwards, we examine the patient by doing a transabdominal ultrasound. But whenever from 4th month to about 8th month, we do only transabdominal ultrasound. But if any patient complains of abdominal pain, any patient complains of spotting or bleeding PV, any patient complains of increased discharge vagina, any patient complains of back pain, then in those cases, we do a transvaginal ultrasound to look at the cervical length. I've talked so much of short cervix. Let me enumerate the causes of short cervix. The most important cause of a short cervix is a past history of a preterm birth. Any patient who has a history of a spontaneous preterm birth, spontaneous preterm delivery, that means before 8 months, that patient has a high risk of being a short cervix. Any patient with past history of cervical incompetence, painless dilatation of cervix or painless delivery at 4th month, 5th month, 6th month is also a high risk case for short risk. any procedure done on cervix in past, cervical biopsy, cervical loop excision, cauterization of cervix, or excessive cervical dilatation more than 10 millimeter, they always predispose to the increased chances of cervical length being short. Also, congenital anomalies like bicornuate uterus, unicornuate uterus, uterus didelphys, history of exposure of diethyl stilbestrol in pregnancy, they also predispose the patient to having a short cervix. Also, in case of uterine overdistension like polyhydramnios, like oligo or twins, they also predispose to the short cervix. And what we have found, there can be a congenital cervical insufficiency also. Sometimes there may be a decidual hemorrhage, decidual inflammation. Also, they lead to the incidence of short cervix. When as a patient, you should visit a doctor for short cervix. Like I mentioned, if you are having low abdominal pain, even if it is normal, ask your doctor to do a transvaginal ultrasound just to look at the cervical length. I'll come to it. Can cervical length be measured transabdominally? Why we should measure cervical length only by doing a transvaginal ultrasound? I'll come to it slightly later in the video. So if you are having excessive white discharge, you are having spotting pervaginally or bleeding pervaginally, you are having low abdominal pain, you are having history of constipation, that is the time that you should visit a doctor. There is a term called as a cervical incompetence or a cervical insufficiency. It is the inability of uterine cervix to retain the pregnancy in absence of uterine contraction. Again, I am telling you, in absence of uterine contraction, that means painless dilatation of cervix or a painless delivery is called as a cervical incompetence. And the risk of recurrence in next pregnancy, if the patient has a history of cervical incompetence or cervical insufficiency, is almost 30 to 50%, and it is usually diagnosed by transvaginal ultrasound. There is a typical funneling of the cervix of the internal os. The internal os gives way. That is how I know that this patient is having a cervical incompetence. Now comes the most important part of this video, how to diagnose a short cervix. My dear friends, transvaginal sonography TVS is the gold standard of diagnosis of a short cervix. How to do a transvaginal ultrasound? Patient is lying supine. We put a probe inside the vagina. Gently the probe is pushed into the anterior fornix. The cervix is measured from the point where there is a slight triangle where the internal os ends to the tip of the external os. In most of the cases, the cervical length should be more than 3.5 centimeter. Whenever you are taking the cervical length, that cervix should be occupying the 75% of the screen, and there are certain precautions which need to be taken. The patient's bladder should not be filled. There should not be an excessive pressure on the cervix from the transvaginal sonography probe. Now, any cervical length which is less than 2.5 millimeter at about between 14 to 20 weeks is called as a short cervix. At 18 to 24 weeks, 10th percentile corresponds to about 25 millimeter, and that is the threshold at which we are worried, especially in patients in whom there is a history of preterm labor. There are various percentiles, various people have worked out. At 15 millimeter, it works out to be 2th percentile. At 20 millimeter, the cervical length, it works out to be 5th percentile. At 25 millimeter, the cervical length, it works out to be 10th percentile. At 35 millimeter, it works out to be 50th percentile. And at 45 millimeter, it works out to be 98th percentile. After 28 weeks, there is a gradual shortening of the cervix. And with each 1 millimeter decrease in the cervical length, the chances of spontaneous preterm labor increases by about 3%. So it is a static structure. It is not a static structure, it is a dynamic structure, and shortening of cervical length basically is because of a continuum of the changes, and as the pregnancy grows, the cervical length shortens. Sometimes, if the cervical length is less than 10 millimeter, then the chances of spontaneous preterm birth are maximum within 3 weeks. However, such are the ways of God that we have found, even if sometimes there is no appreciable cervical length, the pregnancy has even pulled on to about 2 to 3 weeks. So there is no definite 100% guarantee that short cervix would lead to the preterm labor only, but there are multiple factors involved. So the positive predictive value of the cervical length of less than 25 millimeter for a preterm labor is as high as 81% in high-risk females with past history of spontaneous preterm birth. But like I mentioned before, it is only 25 to 40% in females who did not have a past history of preterm birth. So you should exercise caution. That is why the history taking and past obstetric history is very, very important. Obstetrics, as my sir used to say, has a very funny habit of repeating itself. If there is a past history in previous pregnancy of a preterm labor, past history of cervical insufficiency, then we as a gynecologist have to take the extra precaution in this current pregnancy so that the same event does not occur again. This 25 millimeter threshold is very, very important because interventions, whether to do the cerclage, whether to start a 17 hydroxy progesterone, whether to start vaginal progesterone or to start dydrogesterone, will start at this level. Now cervical shortening basically starts from the internal os, and that is why old school people who used to do PV per vaginal examination to look at the cervical length, it does not give a good indication of a cervical length because the funneling starts at the top at the internal os, and that is why digital examination or a PV examination is not a good measure to find the cervical length. I'll repeat myself again. The sensitivity of a short cervix less than 25 centimeter in 25 millimeter in patients who have a history of prior preterm birth. The chances of spontaneous preterm birth this time without any interventions is close to about 70%. While the sensitivity of cervical length who are having less than 25 millimeter cervical length in this pregnancy with no prior spontaneous preterm birth, the chances of spontaneous preterm birth in this pregnancy is close to about 35 to 40%. So that is why the history is a very, very important role. Multiple pregnancy patients, twins, triplets, they have got a short cervix, but that does not mean that they will end up in preterm labor. And short cervix does not occur suddenly. There are different stages of short cervix. Initially what happens is there is slight, normal cervix is like a cylinder. I mentioned in my previous video, it's like a cylinder. So this is cervix, this is about 3.5 to 4 centimeter long, this is the internal os, and there is the uterus on the top of it, and this is the external os, and there lies the vagina. Now this is like a flat line or a slight curve. Now when the cervical shortening starts happening, initially there is a slight opening of the internal os, which is followed by the slight cervical dilatation. Then there is a shortening of the endocervical canal from internal os to external os, and finally there is a full dilatation of cervix. So USG, as I mentioned in my previous introduction, is the gold standard. Transvaginal ultrasound is a gold standard for measuring the cervical length, but it is operator dependent. Because uterus and cervix is a dynamic organ, there is continuous contraction, Braxton is contraction occurring, so sometimes cervical length may be more, sometimes cervical length may be less. And also, very, very important thing, the consistency of cervix, whether the cervix is firm or soft, it cannot be known on a transvaginal ultrasound. For that, a digital examination is must. So like I said, in doing transvaginal ultrasound, few precautions have to be taken. Excessive pressure should not be done with the probe, and there should not be an overtly distended bladder, because overtly distended bladder would give a false impression of a excessive length of cervix. Now when the cervical shortening starts, or in other words, when the process of preterm labor starts, how do I know, how do I predict that this patient is going to go in a preterm labor? Because preterm labor is not a sudden event. One fine day, patient will not have a preterm labor and will deliver. The chain of events might have started 2, 3, 4 weeks back. So initially there is a separation of a decidua on ultrasound. Because of that separation, there might be some kind of sludge or a blood clot, and which most likely infection is the precipitating factor. Then there is slight opening of internal os. The moment internal os opens, the amniotic membrane, it slightly protrudes into the cervical canal, and this is called what we call as funneling of internal os. Then the internal os opens slightly, followed by the shortening of the cervix, which we in our language called as a effacement of cervix. And initially, if non-effaced cervix, non-dilated cervix, there is a T-shaped sign followed by a Y-shaped sign. That means slight opening and the funneling. Then this Y becomes V-shaped sign, the funneling becomes more pronounced. And then as the cervix dilates, this becomes a U-shaped sign. It represents a almost complete effacement of the cervix. Many times, if we do cervical length in hurry, we may underestimate the cervical length. Also, like I mentioned, overtly distended bladder may may give a apparent lengthening of a cervical effect when actually the cervix is short. Also, the underdevelopment of lower uterine segment. I mentioned in my previous videos, as the pregnancy progresses from top of the fundus to the internal os, this is called as upper uterine segment. From internal os to external os, there is a lower uterine segment, and lower uterine segment starts developing mostly after 28 weeks. So underdevelopment of a lower uterine segment, and sometimes placenta previa, the placenta adherent or placenta lying in the lower uterine segment, gives us a false sense of a long cervix when actually it is not. Why do we not prefer a transabdominal sonography as a measure of a cervical length? First of all, whenever we are doing a transvaginal sonography, the ultrasound probe is absolutely nearby to the cervix, and that is why distance is not there. So distance artifact does not remain in transvaginal sonography. Actually, the distance is a major hindrance in the transabdominal sonography. Also, there are various layers of the abdominal wall, skin, subcutaneous tissue, and all those kind of things. And for doing a transvaginal ultrasound, we need a bladder to be filled to a optimal level. Like I mentioned before, filling of a bladder gives us a false sense of a increased cervical length that camouflages the short internal loss. And there are sometimes the fetal part which may block the view, which may obscure the view of cervix. That is why we do not measure cervical length by doing a transabdominal sonography. Now here is a very interesting aspect. I'll come to the biochemical aspect of a short cervix. Cervix has got basically two roles in pregnancy. During the pregnancy till about delivery, cervix basically plays a holding role. And once the labor process starts, it is expected to soften up, to open up. During pregnancy, there is a physiological softening of cervix, which is determined by the extracellular matrix of components, particularly decorin and thrombospondin 2. And the direction of collagen fibers is circumferential, but the collagen solubility increases in pregnancy. Therefore, in pregnancy, the cervical tissue is more hydrated. There is a higher collagen extractability than in non-pregnant tissue. This added resistance to the cervical strain is protective feature of cervix, and overstretching of interspersed cells may control the cervical remodeling. These mechanical properties of cervix are severely modified by the relatively small modifications in biochemistry in pregnancy. There is a higher collagen extractability, the higher hydration levels, there is a more compliant tissue, and the total collagen content, although it remains unchanged, but there are significant changes in collagen cross-linking and components like glycosaminoglycogens and hyaluronic acid. Because there is an increase in hyaluronic acid, it is related to the increase in collagen solubility, and there is a disorganization of collagen network. People have found that women with increased incidence of cervical incompetence have got increased smooth muscle component, and if you go to my starting of the video, this smooth muscle component does not give strength to the cervix. In people with increased incidence of cervical incompetence, the elastic fibers are less, and the concentration of hydroxyproline is less. Hydroxyproline and proline are very important for sharp twisting of the collagen helix, and which ultimately gives strength to the cervix. Hydroxyproline is basically found in collagen only, and that is why the quantification of hydroxyproline may be an indication of cervical collagen. Maybe in future, if research is done, if we do a cervical collagen content and if we find a good amount of hydroxyproline, that means that that patient is not going to go for a spontaneous preterm labor or a cervical incompetence. Cervix, like I mentioned, is a dynamically changing organ. Cervical length may not remain same always, but it does not change much. A 2.5 centimeter cervical length may not become 3.5 centimeter tomorrow morning or 5 days later, but couple of millimeters here and there. It is also an operator dependent. There is an inter-individual variability. I do cervical length, somebody else does a cervical length. There may be a difference of 1 to 2 millimeter. Somebody may exert more pressure, somebody may exert less pressure. In some females, bladder may be slightly more full, in some females, bladder may not be full. Sometimes the cervical length may have been measured during the Braxton's contraction. That may give a short cervical length. So the question is, most important thing is, having discussed all this, how to manage a short cervix. Suppose a patient comes to me at 18 to 24 weeks and that patient's cervical length is about 25 millimeter. What I will do? If that patient is a primary patient with no past history of prior preterm birth, I will just do a watchful surveillance. That surveillance I'll do by watchful surveillance, I mean I will do a repeated transvaginal sonography cervical length at about every 2 to 3 weeks interval. If it is a high risk pregnancy, by high risk pregnancy I mean there is a patient has suffered multiple infections, there is a past history of UTI, there are twins pregnancy, there is a polyhydramnios, there is a high risk pregnancy, hypertensive pregnancy, there are autoimmune factors, it is IVF conceived pregnancy, there is past history of recurrent pregnancy loss, past history of multiple abortions done, then in those cases I may start a vaginal progesterone. Now most of the females don't like keeping vaginal progesterone, because in vaginal progesterone many times it happens that there is an itching. and they find it messy. But vaginal progesterone is very good and very, very effective. Vaginal progesterone has to be kept as near to cervix as possible. The length of vagina is about 10 to 12 centimeters long. So the female has to push the vaginal capsule either with the applicator or with the finger as far as it goes, and it should be as near the fornix as possible. We can also use 17 hydroxyprogesterone weekly, 250 mg per ml or 500 mg per 2 ml depending upon the case. Vaginal progesterone should be continued till the date of viability. We normally start vaginal progesterone in any females in which there is a cervical length of less than 25 mm, especially those females who have not reached 25 weeks of pregnancy, who do not have any preterm labor symptoms, and there is no prior history of preterm birth. A 200 mg vaginal progesterone capsule before 34 weeks kept, it increases the chances of patient reaching 34 weeks by about 20%. There was an EPIC trial done. EPIC means Evaluation of Progesterone for Prevention of Preterm Delivery, an international collaborative. It examined the effect of modification of short cervical length and data of 4 studies. And the conclusion of this trial was that you have to start a vaginal progesterone in any female who has got a cervical length less than 20 mm. From 21 to 25 mm, there is a gray area. From 21 to 25 mm, whether to start progesterone or not, the decision can be made in a shared decision-making model. You can tell your patient that we have to do an watchful surveillance every 1 week, every 2 weeks, and the moment the cervix is less than 20 mm, we'll start the progesterone. But the threshold at which to start progesterone is not decided worldwide. I take a threshold of 25 mm. Despite no lack of clarity, despite no lack of clinical studies, but because vaginal progesterone is harmless, American College of Obstetricians and Gynecologists has recommended the uses of vaginal progesterone as a management option of a short cervix. Many doctors do cervical encerclage. Cervical encerclage is the placement of a non-absorbable. Mind you, non-absorbable is the important term. Either you use Prolene or you use an epimide. But some doctors use Vicryl, which is a delayed absorbable. I personally believe a Vicryl stitch should not be used because it is a delayed absorbable. There are chances that it may get, the blood may get absorbed in it and it may get infected, and infection may lead to the chances of a preterm labor. So cervical stitch, we normally use cervical stitch as close to internal os as possible. The placement of a non-absorbable stitch to mechanically support the cervix, to reinforce the cervical length, and thereby giving an apparent lengthening effect of cervix is very, very important. The secondary aim of the primary aim is to hold the pregnancy, and secondary aim is to lengthen the cervix. Bergel et al., they have demonstrated that achieving a cervical length of more than 2 cm after cervical stitch reduces the chances of preterm birth. Even achieving the 10 mm cervical length after cervical stitch is associated of prolonging the pregnancy. When do we do the cervical stitch? Excuse me. We do a elective cervical stitch in all those patients who have got a past history of cervical incompetence or a cervical insufficiency. Whenever there is a past history of preterm labor and cervical length is less than 25 mm, in those cases we do a cervical stitch. Sometimes we do a ultrasound guided cervical stitch in which cervix continues to get short in spite of continuing a vaginal progesterone. We also do sometimes we do a emergency cervical stitch when the cervical length is less than 10 mm. But if cervical length is more than 2 cm and there is no funneling, then there is no indication of doing a cervical stitch. If cervical stitch should only be done if there is a funneling. Otherwise, if it is more than 2 cm, then the vaginal progesterone can be continued. Cervical stitch is also done in cases of congenital malformations of uterus like biconate uterus, uterus diadelphys, and septate uterus. Because in those cases there is a small cavity. Small cavity means as the baby expands, the cavity may not get big, so the baby may be slightly on the lower side, and there may be increased chances of a preterm delivery. The current evidence does not support a routine use of a systemic or oral antibiotic before using a cervical stitch. Treatment of a documented vaginal infection is warranted before taking a cervical stitch. Indomethacin tocolysis should be done before taking a cervical stitch. and data regarding continuation of progesterone after taking the cervical stitch is not clear. But there should be more of a rest after taking up the cervical stitch. Patient should not be doing heavy work. Having said that, I practice the usage of vaginal progesterone even after taking the cervical stitch till the age of viability, that is 34 to 36 weeks. Sometimes we have to do something called as an emergency or a rescue cerclage. Patient has come to me in the OPD. Patient is complaining of a low vague abdominal pain, and I find that cervical length is only about 10 to 15 millimeter. Or sometimes there is a bulging of a membrane. There is slight cervical dilatation. In those cases, we have to take the emergency cervical stitch. This is called an examination indicated cerclage. What I do in such kinds of cases, immediately I admit the patient, take a vein flow, start a injectable antibiotic, put the patient on a at least 6 to 12 inch foot end elevation, put a Foley's catheter inside, give a local vaginal pessary of clotrimazole or clindamycin, give 4 tablets straight of dydrogesterone, and I normally keep 600 milligram of vaginal progesterone. I also give injectable progesterone. I also give injection 17-hydroxyprogesterone. Wait for 4 to 6 hours. If the pain has subsided, then I take the cervical stitch. What I have personally found, if patient comes to me in OPD directly, the cervical length is less, and I immediately do a cervical and cerclage, then the labor process is already started. I first need to arrest that labor process, and that is why I need to wait for 6 hours, 12 hours, and then do under a controlled environment after giving indomethacin tocolysis, after going for a good antibiotic coverage. However, there is an insufficient high quality data regarding the follow-up or a surveillance of cervical length after the use of a cervical and cerclage. Also, the role of USG indicated cerclage without prior preterm birth in the history of patients who have a persistent cervical shortening despite the use of progesterone is not clear. We do not do routine cerclage in twins pregnancy. We do not do cerclage in patients who have got a premature rupture of membranes, and we also do not do cerclage in which the dilatation of cervix is more than 4 centimeter. After all these huge barrage of short cervix, most of the patients ask me, sir, can short cervix be prevented? While it is not technically correct to say that short cervix can be prevented, but we can take the measures so that the cervical shortening does not occur. Good, regular antenatal checkup has to be done. Early identifications of infection and minimize the chances of complication is very, very important. Well-balanced diet, plenty of hydration. Prevention of infection. I have said in my preterm video, most of the causes of preterm labor are infection. There are 4 infections which can commonly occur in pregnancy. One is a upper respiratory tract infection, one is a gastrointestinal infection, one is a urine infection, and last is a vaginal infection. For prevention of upper respiratory tract infection, most of the females I advise usage of mask, especially when they go out of their home, and hand sanitization is very, very important. If they are having upper respiratory tract infection symptoms, steam inhalation and hot hydration is very, very important. For prevention of a gastrointestinal or a stomach infection, strict avoidance of any food from outside, hotel, laris, everything. Strictly, I tell all of my patients to drink the boiled water, even if it is from RO. Water has to be boiled and then cooled and then drunk. People should not be drinking water from fridge. Ice cold water or ice drinks, ice cream should be avoided. It can lead to sore throat. Clipping of nails is another thing which I have found. It is a very bad hygiene measure, and that can lead to an gastrointestinal infection. For prevention of urine infection, at least 3 to 3.5 liters of fluids per day, which may include nariyal pani, which may include lemon water, which may include simple plain water, which may include buttermilk, which may include milk, tea, coffee, whatever you want, but no fruit juices. And prevention of vaginal infection is by having at least 1 bowl of curd, that is a probiotic, and plenty of green leafy vegetables. Also a well-balanced diet which includes more of a protein, more of omega-3 fatty acids. Omega-3 fatty acids are available in variety of nuts. Walnut and almonds are best for them. And there should be good protein supplements and avoidance of a unsaturated foods. In lifestyle changes, I have mentioned you should be staying hydrated. There should not be much sedentary lifestyle. You should be minimally active. You should be walking, slight yoga and all those kind of things. But avoid heavy work. I always advise my patients in pregnancy, no jhadu, no pocha. You can make your food. but continuous squatting at least before 30 weeks, it puts pressure on the cervix, so you should not be doing this. Fruits, vegetable, green leafy vegetables, sprouts, everything should be eaten. Should one do bed rest for a short cervix? If there is a documented past history of spontaneous preterm labor, if there is a documented history of a cervical incompetence, then yes, I advise not complete bed rest, but plenty of rest after taking the cervical stitch, and that rest has to be till 34 weeks. If there are multiple pregnancy failures, multiple bed obstetric history, multiple preterm labors, then we put the patient on a complete bed rest. We ask the patient to stand only for passing the stool or urine in that case. Suppose there is a twins pregnancy and short cervix, and there is a no past history of a spontaneous preterm birth. What do I do in such cases? In twins pregnancy, we do not routinely take cervical stitch. There is no indication of taking the cervical stitch. The only indication of taking cervical stitch in twins pregnancy is when there is slight cervical dilatation. Otherwise, short cervix is not the indication of taking the cervical stitch. Now, there is a dichotomy in this. Suppose that twins pregnancy has been conceived after IVF treatment, and before IVF there was a congenital anomaly of uterus. Either it was a unicornuate uterus, or it is a bicornuate uterus, or there was a septate uterus, mild septum, or we have done a lateralization, we have put a lateral cut on the uterine wall, septoplasty has been done, in which the cavity is small. In those cases, if there is a twins pregnancy, we will go for a cervical stitch prophylactically. If there is a cervical insufficiency, suppose a 16 weeks in last pregnancy, then we put a prophylactic cervical stitch after doing the NT scan. First of all, we take a good NT scan. We do double marker or NIPT, and once we find that baby is fine, then at about 13, 14, 15 weeks, we do a elective cervical stitch. We normally put a cervical stitch about 1 to 2 weeks before the last time the spontaneous preterm labor or cervical incompetence occurred. Sometimes patient has come for a routine checkup and incidentally we find that there is a short cervix. What do we do in such cases? ISUOG, it is an International Society of Ultrasound in Obstetrics and Gynec. It says that we do not need to do a universal screening of cervical length. The algorithm of Bergela suggests that just do a cervical length at about 14 weeks, and in high risk patients, by high risk I mean that there is a past history of a spontaneous preterm birth, past history of a cervical length, cervical incompetence. In those cases, you have to assess cervix every 2 weeks. But in non-high risk patient, we do not need to assess cervix. In incidental patients, we just need to monitor cervical length every 3 to 4 weeks. If there are no complaints, we do not need to do anything. Suppose the cervical length is less than 20 millimeter, then we will definitely start vaginal progesterone. Cervical length is between 21 to 25 millimeter. We will discuss with the patient. We will discuss that we would be needing to do a frequent cervical surveillance every 2 weeks. And the moment we find that cervical length decreases to less than 20 millimeter, then we will start progesterone. If in spite of starting progesterone, or if during monitoring of cervix there is a funneling of cervix, then we would take the patient for a immediate ultrasound indicated cervical and cerclage. But females without the history of preterm birth and who have evidence of cervix which is less than 25 millimeter, there is no indication of cervical cerclage if there is no cervical dilatation or if there is no funneling. So the carry home messages of this video, there are 3 things. A routine cervical and routine cervical length should be taken at about 12-14 weeks, and then again at 24 weeks. If patients have past history of spontaneous preterm birth or past history of cervical incompetence, in those cases we will monitor the cervix at every 2-week interval. Less than 2.5 centimeter cervical length, we would start vaginal progesterone or 17-hydroxyprogesterone till the date of viability, that is till about 34 to 36 weeks. We would do cervical and circular cervical stitch in only those cases in which there is a documented past history of spontaneous preterm birth or a documented past history of cervical incompetence or a painless cervical labor. Or during our surveillance we find that there is a funneling of cervix. In twins pregnancy, routine cervical cerclage is not indicated. Even the routine use of progesterone is not indicated in twins pregnancy, but we, as a matter of caution, we normally give vaginal progesterone or 17-hydroxyprogesterone depending upon the case severity, because most of our patients are infertility conceived. But some doctors do take cervical stitch by just doing the pervaginal examination. That is a totally wrong technique. Cervical stitch, whether to take or not, it always and should depend upon the TVS cervical length and 2.5 centimeter or 225 millimeter is the cutoff at which you should be taking the cervical stitch. We have made a video on preterm labor and cervical and cerclage. Please go and see it. Please like the video. Please share the video. If you have any comments, any questions, please write to us and please subscribe to our channel.